All right, well, we will go ahead and get started. I'm excited to welcome you all to today's webinar. This is CPQCC's inaugural Toolkit release webinar. So we're happy to be able to present to you the preventing hospital-acquired infection in the NICU. Just a couple meeting logistics to start off with. Everyone is automatically muted when they enter the meeting, and if you could stay muted unless you're speaking. Feel free to use the chat function to post comments or questions during the presentations, but we would like to hold off on you asking questions just during the Q&A panel discussion at the end of the webinar. So at that time, you could unmute and ask your questions if you wanted to. So feel free. The slides and the recording will be posted to the CPQCC website following today's session. And we do have the HAI toolkit posted to our website today. If you have any technical issues, please feel free to send me a private message at Janine Bonert. Today, we are offering continuing education credit for RNs. So if you haven't already, please make sure that you sign in by chatting in your name and institution to the chat. And then at the end of the webinar today, I'll have a link and a QR code for you to submit the evaluation. So today's agenda, we are going to start off with a review of HAI NICU data, and then an introduction to the HAI toolkit by each of the toolkit authors, presenting their sections, and then we'll end with a Q&A panel discussion. So just to note, there is a whole team of people behind today's webinar. We had a group of people from the QI Infrastructure Committee involved in planning this, as well as the toolkit authors who are also presenting, and facilitators of the Q&A moderation. So thank you all. And as our presenters start their section, please introduce yourselves for everyone. So I will turn it over to Dr. Lee.
Hello, thanks Janine, and thanks everyone for being here. I'm Henry Lee, neonatologist and representing CPQCC here, also working at UCSD. Yeah, I'm very excited to sort of kick things off for our webinar and introduce this toolkit, which I'm grateful for all the authors as well as our PQIP members who have been involved in getting it to completion. I'm so excited to hear their presentations. Janine, you're gonna advance the slides for me, thanks. So just a little bit of history. CPQCC started in 97, 98, and our membership has grown, and as probably many of you are aware, our collaborative is considered really a leading perinatal collaborative, perhaps being the first, but also an innovation in quality improvement as a role model for many other state collaboratives. And really toolkits from a very early time period in the collaborative have been a critical part of how we do quality improvement. And the toolkit is also the starting point for collaborative work together across NICUs. These are sort of perhaps the predecessors for the current toolkit, the nosocomial infection reduction toolkit 2003, and then updated in 2006. You can see I think actually it's still up on our website, this older toolkit, and I imagine many of the principles there are still relevant that our colleagues have built on over the years. Next slide. And so with this toolkit, actually, just like today, even though you might think that the pandemic led to this wave of webinars and collaborations and learning in this format, but back in the day, we at CPQCC also had webinars, in that introducing that that 2003 and 2006 toolkit. We also had in-person meetings, regional meetings, to disseminate the information in the toolkit, and of course we continue to do that as well. But even back then, we were disseminating toolkits through similar formats, really trying to get together to learn from each other. You can see here a study published that sort of outlined results, the success, so to speak, of even that toolkit dissemination back then, where participating hospitals who attended such webinars and in-person sessions had a reduction in nosocomial infection that was significantly more so than those who did not participate, who were also members of CPQCC. Next slide. Yeah, and then this is just another study that similarly showed the reduction in central line associated bloodstream infections associated with dissemination of the toolkit. And in that paper, some of the principles outlined, which I think we've built on over the years in CPQCC, are local leadership commitment, both across the NICU in terms of multidisciplinary work with neonatologists, nursing leadership, and others, and leading this work and outlining potentially best practices, using the evidence when it's available, but also just learning practical tips from others in a collaborative process, both within institutions, but also across institutions like we're doing today, using audit and feedback tools and just implementing quality improvement techniques that, again, we've also learned so much from each other just by having meetings like this. You can see some of the names there in that list, and also who are members of the Toolkit writing group, David Wirtschafter and Janet Pettit, whom I'll mention in particular, who are really were pioneers in quality improvement, and particularly contributing to so much of the work that we've done in CPQCC. And as you might know, CPQC, we have awards that are named in their honor. Dr. Wirtschafter, who was with Kaiser for many years and still continues to participate in our research committee, and Janet Pettit, who was at Doctors in Modesto, a nurse practitioner who contributed so much to CPQC in many ways, but in particular, I think her work in line infection reduction, hand hygiene, was such a great educational sort of a resource for so many of us. Next slide. This is just a figure from that paper, and maybe perhaps we think nowadays, it's a line infection reduction is a simple thing, we use checklists and have certain processes, but I think their work back in the day really helped us to kind of figure out what are the main principles, and as they investigated. So, and this is just one figure of actually many that sort of led to their thought processes that led to some of the quality improvement principles for infection reduction that we use today. Next slide. This is a result of the work that was done back in the day that led to the reduction across many of our centers in line infections. Next slide. Yeah, and then we participate as a state in a national collaborative where we tried to learn from other states as well in their collaborative efforts, and that was back in 2011 to 2013, and Balaji Govindswamy, Joe Shulman helped us to participate in that national collaborative, and so many of our CPQCC members participated in that as well. This is a figure from that paper showing on the x-axis number of catheter days in the unit, and then the y-axis is line infections. What it kind of illustrates is that even those centers that had very high catheter days didn't necessarily mean that you had more infections. Sometimes we think that, if you're a unit that's maybe sicker patients and higher acuity, that is it's acceptable to have a certain infection rate, and there there's something to that. I want to say certainly that does increase the risk, but we see some centers who have that population who are still able to achieve very low rates. Next slide. This is, if you look at CPQCC reports on a regular basis, this could look familiar to you. This is a report from the website, and this is all of CPQCC, so not any individual center. And I think what you see here, this starts at 2006 up to current year. And I mentioned 2003, 2006, and then 2010 to 11 are the years where we sort of had concerted efforts across centers to reduce infection. And as you might also know, we haven't had a toolkit necessarily for infection reduction, since then either. Of course, we've done so many other things that you have all participated and contributed to in so many other clinical areas. So I look at this figure, and this is nosocomial infection, which is one way to sort of characterize what we consider late infections, maybe hospital-acquired infections, including line infections. And so perhaps I like to see this and think that, oh, that work that we've done together across those years, from 2003 up until 2012, led to that very dramatic decline in infection rates across California NICUs. And then since then, it's kind of been, pretty stable across our state. Now, we might think, that's perhaps because we've done all the work that we can in reducing infections. We know the principles, and perhaps there's a baseline rate. We expect some babies, if we use lines and the equipment that we use, maybe it's inevitable that one or two babies are going to get an infection here and there. And so maybe this is the lowest rate that we can achieve as a state together. On the other hand, maybe I like to think we haven't really had a concerted effort in infection reduction as a state collaborative since 2011. So I do think it's really an opportune time for the folks who have collaborated in producing this toolkit to introduce it. And this is the start of the dissemination where I would like to see, can we push the needle even further to go below this rate that we have been at now for about 10 years? I think we can. So I'm really excited for this webinar and our collaborators. Next slide. This is just breaking it down to babies over 1,500 grams. I forget if the last slide was all babies or less than 1,500, but this is supposed to illustrate really it's both groups, it's all the babies, both groups less than 1,500 and greater than 1,500 grams in our NICUs. Next slide. And why I would like to think that we can go lower is that even with that baseline rate, we still see, this is last year's data for our very low birth weight babies, that there is variation across our centers in terms of infection rates. And it is true, as you look to the left of the figure, that many of those NICUs that have achieved a 0 infection rate are smaller, and that's why the confidence limits go all the way up to 100, because they don't have as many babies. But you will see that that's not all those NICUs that have 0. If you look, the zeros go all the way up to units that actually have quite a few babies. The volume is quite high in some of those units that have achieved 0 infection rates. And then towards the right, you do see units of all various sizes that have a rate that's higher than average. And so, and I think I really appreciate our collaborative being one where we work together. We probably in our units are doing some things well, some things we can improve on. And so I think particularly for those units that are either at the average or higher, this is perhaps an opportune moment to get your unit excited about working on this issue. So this is what I think I predict for the future. 2022 is when we kick off this infection HIE reduction collaborative sort of effort. And so I look to our leaders in this regard to help us to accomplish this goal.
Thanks so much, Henry. All right, over to Robin to bring us into the HAI toolkit. You're muted. Oh, there we go.
Can you hear me, I hope?
Yes, sounds great.
Good. Thank you all. This has just been a really exciting day for all of us, and I appreciate Henry Lee sharing and really introducing our topic today, because our section writers, we all believe too that there's maybe more to do. And so we sort of designed this toolkit with the thought that maybe there is more to do. And to broaden our focus, first slide for me, Janine. Oh, that's right. So I need to introduce to you before I get started that one of the questions we asked all of you when you registered was, were you aware and or using the toolkits that are available on CPQCC? And we're excited, I think CPQCC is especially excited that 90% of the respondents are aware of these toolkits and only 10% of you weren't. So I think we're incredibly fortunate in California to have this resource, especially when you're working hard on a topic that you are looking for resources. And I think CPQCC is a great place to do that. And we actually wrote this toolkit with resources in mind, really heavy to do that. That was our big focus. So that's great. Next slide. So getting back to what Henry presented, and I'm passionate about hospital-acquired infection reduction, and I was on one of those early collaboratives working hard on that fishbone to get things moving, and I learned a lot. And so I really wanted, in introducing this toolkit, to recognize David and all that work. I experienced learning from him too, and I think much isn't different from his initial quote that he provided in the past toolkit, that we really need to do some self-analysis and really look at our own data and see how we can be better. And I think our babies deserve us, our babies and families deserve us to work harder and really reduce the burden of infection. And our goal on releasing this toolkit was to encourage you to broaden your idea about your work. It's not just CLABSI, although CLABSI, you should be sure your work is good in that arena. But there are other areas that you might want to look at and see if you can't push your numbers even lower by doing some other potentially better practices. So we've introduced some of those today. So our goals in writing this toolkit was not to duplicate or duplicate other evidence-based guidelines that are recently published. In fact, we started this work during the pandemic, and during that time, many of these resources were updated and published. So that I'll go over that in my section, what those are, but there are several for CLABSI reduction where they are NICU specific and are helpful in some cases. We're learning more. We also, in this toolkit, really wanted to push giving examples of tools and resources. So the examples may not be your practice, but please consider those examples as a way to leverage some of your work. So if there's a visual resource guide, it's not exactly your practice, but see how the guide was put together and consider how that guide might work for you in your unit. Something I learned from David early on was that NICU practice is very NICU specific in your NICU. And so I live and breathe that every day as the clinical nurse specialist at the University of California, Irvine. And we all have our own barriers and we all have our own practice challenges. And so QI needs to work for you. So you need to work within your setting to try to reduce HAI as low. We can get to zero, much like CLABSI work. We didn't think we could get to zero, and many centers have realized zero for extended period of time. So we really want this to be a resource seeking additional HAI prevention strategies that might enhance your existing practices. Over 34 tools and resources for you to consider. So the way we organized this was putting HAI prevention in the middle. We felt hand hygiene is always the foundation. And so that is our first section. And I want you to relook at all your hand hygiene work and consider other ways to enhance that. It may not be as good as you think, or even high compliance still has opportunities to improve. So we really felt like that had to be our foundation. We added a new section all about quality improvement and our NICU culture. And I think that that is some of the secret sauce that people talk about on how to improve and reach some good outcomes. Is you have to look at what your unit culture is, their capacity for doing something, and also what kind of leadership is there to help you get that done. Then we have a general principles section with some potentially better practices or additional interventions you might consider. And then skin considerations weren't really addressed in the previous toolkit or not addressed very specifically. And we all felt this was important. The skin is included because, as we all know, as we push down to 22 weeks, skin protection integrity is vital to HAI prevention. And then finally, antibiotic stewardship and diagnostic stewardship and MDO prevention is key as well to reduce your overall HAI. So this is how we visualized this toolkit, and there are tools and resources within each section. So I'm excited today's finally come after almost 2 years of work. I can't go forward without saying thank you. The NICU leaders and clinicians who are willing to share their resources and tools with us, I am so very grateful for them, and it's greatly enhanced our toolkit. And also the section authors who are on today, again, through a pandemic, having to continue review newly published guidelines as they were coming out. I really do appreciate working with all of you, and I feel like your time and effort's really going to help NICUs across California. With that, our first section is going to be presented on hand hygiene.
So I'll take it from here. My name is Rochelle Tsai, and I'm currently working as the clinical nurse specialist at Sharp Murray Birch Hospital for Women and Newborn in San Diego. And just as Robin mentioned, reducing hospital-acquired infections is definitely something I'm passionate about, something we worked on. And I remember as a new CNS, I've been a CNS for just about 15 years now. And I remember as a first CNS, one of the first toolkits I pulled off of the CPQCC website was that HAI prevention toolkit and working on reducing CLAPSIs in our unit. And so I really enjoyed working as an author on this toolkit and working with the other authors to present what we have created for you today. And then Sue Bowles is also going to be co-presenting this hand hygiene section with me. So I don't know if she wants to do a quick introduction of herself before we move.
Yeah. Hi, everybody. It's Sue Bowles from sunny Florida. I'm a member of the Florida FPQC, but I actually worked with Janet on the first toolkit, and I am so grateful, as everybody said, to her and David's leadership. And Rochelle, I can't believe it's 15 years. I remember when you first started. I feel old, but thank you all for allowing me to continue this important work.
So hand hygiene, as Robin mentioned, it really is foundational to the work in reducing hospital-acquired infections, and it's really the single most effective strategy that we have to reduce HAI, and it serves as that foundation. We also know that HAI prevention efforts should begin with our detailed review of our own NICU hand hygiene practices, protocols, and staff education efforts. Even despite in some of our units, we report really high hand hygiene compliance. I think if we really do a deep dive and really look down into the bed space challenges or specific unique designs we have in our units, or the unique challenges we have in the NICU, just while giving care, we touch something in our environment, go back to the patient, and all of those unique opportunities we have for hand hygiene. If we were to do a deep dive, I think we would find more opportunities for improvement. I mentioned that we have a lot of complexity in our NICUs, and so while hand hygiene is their standard protocols out there, our NICU environments create a lot more complexity that we need to address and may need to move beyond just some of the foundational tools and recommendations that are out there and customize our hand hygiene approaches in our own units, as we have various unit designs from single patient rooms to open bays or a hybrid of both in some of our units, and also really considering the fragility of the infants that we care for, sometimes 22, 23 weekers, and the different challenges that those patients pose, as well as we're looking at hand hygiene practices. So the approach that we took to working on this section of the toolkit, we did look to the original toolkit. Hand hygiene was covered in the original toolkit, looked at some of the evidence that was used in that toolkit, and continued to use the CDC guidelines as well as the WHO recommendations and the 5 moments of hand hygiene as the foundation and gold standard for the approach to this section of the toolkit. But we also wanted to move beyond that because we know that those guidelines need to be augmented by additional NICU specific content. And so we did conduct a literature review looking at specific things that impact the NICU, and those are covered in the toolkit. So we looked at things like universal gloving. We looked at how to engage and integrate the families into our process for hand hygiene monitoring. And we also looked at innovative ways to provide feedback to staff about hand hygiene, compliance, and real-time feedback. And then as Robin mentioned, we did look to some of the existing tools that are available that other NICUs are using or what's available in some of the published guidelines, and included some of those tools in our toolkit. And in a few minutes, Sue will go over some of those tools that we have. So the potentially better practice that's outlined in this section of the toolkit is to establish hand hygiene standards and compliance monitoring as an integral component of a robust hospital-acquired infection reduction program. And as we've already mentioned, hand hygiene is the single most important factor in preventing the spread of pathogens and preventing antibiotic resistance within our settings. And so it really should start as the foundation in preventing and reducing infections. And in order to do that, we should take a multimodal approach to hand hygiene improvement that includes education, monitoring, and reporting of our compliance. And you can use a multitude of different formats for your training and education with staff, and using hand hygiene monitors to help with compliance through observation of our hand hygiene protocols, and use of real-time peer-to-peer feedback is important. And then the family, as I mentioned, we did try to address how we can incorporate and integrate the family into this process because they are an integral part of our team. And using active patient and family empowerment might also help to increase our hand hygiene compliance among healthcare providers if we're using them and engaging them as active participants in our cross-monitoring for hand hygiene in the NICU. So I'll pass it on to Sue to cover a few of the tools that we included.
So this is one of the tools, and this is a great example that a nursing leader could do, is just take this leader guide, and when she's doing her leadership rounds, incorporate this guideline into the tools. And one of the things I do want to say with the hand hygiene tool, whether it be an observational tool, whatever you're using, don't feel like you have to wait for the next invention of the computer to use it. You can do paper and pencil and get the information that way and then go back. But I really think the observation and using the tools that are out there will really help. Next slide. This is another tool that I particularly like. This comes out of the CDC, and this is a tool that looks at they have 9 specific tools, but this one is specific for hand hygiene. But what it looks at is the equipment, because one of the things that is coming out that we see is one of the biggest ways where people are not washing their hands is if they don't have access to a sink or to the foam or whatever. And this tool again helps you to look at that. And again, it can be a paper and pencil tool. Next slide. This is one of the other tools that's available, and this is a great one because this is the 5 moments for hand hygiene in the NICU, but it's specific to the NICU. And I'm a former Army nurse, and I liken this tool as kind of a bunker. You're creating a bunker for that baby and keeping that baby safe. And I think it's a great visual tool that we can use for our 5 moments. And it's something if you have a Gemba board or a huddle board, you can put this up there. You can put it in different places around the unit to remind both staff and parents what they need to do in terms of hand hygiene. Next slide. So what are the barriers? Well, the first barrier, and I'm having a little trouble, is the skin dryness and irritation. And when we did the first toolkit, we weren't aware of some of the stuff, but now a lot of the products that are out there are better made, and you can use products that will help with that dryness and irritation so that people will wash their hands. Our second barrier was a lack of knowledge about guidelines and hygiene moments. And again, that's where the tools like the previous tool can come in and help with that. And then finally, the last one is lack of awareness about hand hygiene compliance in general. And again, once you have your observations and you can put it into a graph, a bar graph, or a run chart, however you want to do it, posting that, whether you post it at a huddle board, a Gemba board, making it available at your staff meetings, it's a great way for staff to become aware of it. And also do make those aware by specialty. So for example, make sure the nurses know what their percentage of hand hygiene is, the physicians, the residents, the specialists, the respiratory therapists, because each of us can, and the parents even, we can each take accountability for our actions that way. Next slide.
So I'll close out this hand hygiene section by just talking about some suggested outcome balancing and process measures. So each section of the toolkit has suggested outcome balancing and process measures that can be utilized to monitor compliance or how you're doing in those different guidelines. And so for hand hygiene, there's a few that are mentioned here, as Sue just mentioned. Looking at overall hand hygiene, but also looking at hand hygiene compliance by discipline is really helpful. But I think when looking at all of these different suggested items for your measurement, you need to consider methods that really will ensure sustainment of results for your unit, and maybe looking at monitoring specific hand hygiene practices that are unique for your unit, or where you see gaps or have identified opportunities. And some of these can be posted in break rooms or covered in staff meetings, or even sharing some of these results with family advisory boards and seeking feedback from families on how they perceive or can suggest improvement in some of these areas as well. And then some of the other innovative strategies to help provide feedback and sustain your measurement goals is maybe developing some interdepartmental competitions with posting results, maybe use of electronic message boards where you can post this information for your staff to see and real-time methods. And then also with leadership rounding, as Sue mentioned, or with patient family rounding, including hand hygiene as part of that rounding and discussion with staff and families. So those are just some ideas.
Thanks, Rochelle and Sue, and we'll pass it over to Dr. Nick Mikas.
So I just want to thank CPQCC for having the opportunity to actually present this information. And I want to thank Rochelle for putting the slides together with me. And I also want to thank, I think most importantly, the folks, the recognizable faces on the screens that I'm looking at, who've taught me so much over the years and have really helped to shape the way that I practice and the issues that we, this wouldn't have happened without all of you. So thank you for all you've taught me over the years. Next slide. So we're going to talk a little bit about building the foundation. And the reason I think it's important is putting bundles together is great. And I think bundles are incredibly important. But I think the reason that planes don't fall out of the sky isn't because there's a checklist, but because the teams that are using that checklist believe that it's going to keep planes from falling out of the sky. And I would make the same argument for the NICU. If we're really getting to zero infection, people have to believe that what they do matters. And I think especially emerging from the past 2 years in a circumstance where there wasn't a lot that we did have control of, understanding that we do have control over some things. And to Henry's point, if we don't believe that everything is impossible until it's done. And I think of the units I work in or have worked in who have gotten to zero. And I think on some level, there was hesitancy at the beginning that we were actually going to get there, but we had to push through that to actually get there. So I'm going to make the argument that zero is in fact possible. But there's some things that definitely need to come into play because the work we do is incredibly complex, and it doesn't fall entirely on any one individual to make the difference, yet we all do together. Next slide. So approaches to reducing HAI, I will insert a disclosure here, which is that I actually don't own stock in any of the various methodologies that all, in my mind, are kind of religions that lead back to the same place, which is that if you there's bits and pieces that allow people to copyright these methodologies, but at their core, they all fundamentally are based in the fact that as we work together as teams, we're going to behave as human beings first. Human beings are inherently fallible, and we have to create an environment where we're doing tasks that are this complex to be able to help each other to do the right thing and building systems to help us to do the right thing to get the outcomes that we're all after. So whether it's team steps, whether it's HPI, whether it's CUSP, whatever units are using, I would challenge us to not limit it to the tools that are within that toolkit, but to look at the others that we might want to bring in to keep our patients as safe as they can be and our staff as safe as they can be, because our staff wants to get to zero. Whether they believe it's possible or not, that I think all of us want to believe that we can impact our patients' outcomes and be able to deliver to the family a course that isn't more complicated than it needs to be. Next slide. So there's 4 potentially better practices that I'm putting forward. None of them in and of themselves are that complicated, but I think they're years in the making, and they can be really complicated, even though they seem super simple. The other argument I would make is for those who think that a lot of this stuff is touchy-feely, there's actually good science behind every single one of these, and we'll talk about them a little bit. So first is having the audacity to target zero hospital-acquired infections. And I don't mean this just in the NICU, I mean throughout the entire institution, because as soon as we let the inevitability creep into it, as Henry referenced, well, you know, that maybe this is as low as we can go. As soon as we give ourselves that permission, the patients we care for are incredibly sick. A lot of them, they're incredibly small. There's lots of reasons that they can have eclampsia, and there's things that we can do actively to reduce that risk. So both can be true, and I think although not every hospital that has set a goal of zero has gotten there, what I would tell you is there's probably not a lot who have gotten there without setting a target of zero to start with. So I think being able to put out there that we can accomplish this, we can get to zero, and there's a path moving forward that'll get us there. Potentially better practice 2 is fostering a culture of safety and learning. There's no chance of getting where we need to go without actually knowing what's happening at the point of care. And without people being able to talk with one another about what's actually going on. If the defects are there and nobody's speaking about the defects, then we're never gonna get there. And there are multiple tools out there. We've provided some links to them. There's multiple tools out there to look at what a culture of safety looks like and how units are doing in terms of a culture of safety. What I would argue is that as the care becomes more complex and there's more individuals involved in a baby's care, whether it's hand hygiene, whether it's line changes, whether it's any aspect of the care that we're delivering, we have a team of people who can all help to keep one another safe, but only if it's an environment where that's okay. And we can't be willing to offer advice or offer constructive feedback if we're not willing to receive that feedback as well. And so it really becomes about the unit you're creating, the culture you're creating, but culture comes from behaviors. And so looking at simple behaviors that you can enact that will lead to a change in culture, rather than starting with, we're going to have a safe culture, which is very nebulous and difficult to wrap your arms around, versus I'm going to do everything I can to keep you safe. And that includes whether I'm going to forget to wash my hands. I just am. There are going to be times where, even with the best intentions, I'm going to forget. What I need from you is to tell me if that happens so that I can wash my hands, as an example. Becoming a highly reliable organization. Again, this is where there's multiple different organizations out there that can help you. There's also multiple toolkits out there that can help you. At the end of the day, it becomes about setting an expectation and then doing all you can to ensure that that actually happens. And if something doesn't work the way that it should, you try to get to the root of why it didn't work the way that it should. So again, there's multiple different methodologies to get there. At the end of the day, what we're talking about is hardwiring into a system expectations, and making it as hardwiring expectations into a system not only of how we behave, but of the things that we do and what we hold one another accountable to. This seems very daunting, but you can start very simple with agreeing to one intervention. And we're going to make one intervention to try to get ourselves closer to zero. And we're going to hold all of ourselves accountable to that. And this is what that conversation looks like if we're not as accountable as we ought to be. And then understanding the impact of human factors engineering and making it easier for healthcare providers to do the right thing. If you have multiple options, people are going to pick, even without knowing, they're going to pick the wrong thing. or we're not going to remember every step of doing a procedure that's more complicated. As we bring new people in with new training, if there isn't an explanation of exactly how it's going to happen and what's expected, then we're going to have 8 different types of dressings as an example, some of which may not be consistent, some of which may make people uncomfortable, some of which actually may not be as good as others, some of which people may not even realize are intact, may think are intact when they're not. So having a standard approach to take and really hardwiring that approach and not providing additional options that are just going to get people confused at the end of the day. Next slide. So some guidelines: implementing leadership rounding to assess reliability behaviors and challenges that people are facing, and believe what staff is telling you. If you have an expectation of what staffing looks like or what supplies are available and staff is telling you that they're not, start with they're not. Standardizing processes to build redundancy so that if, regardless of who's there, the expectation of behavior is going to be the same, which will help with leadership changes. It'll help with the unit owning the standard, so that as nurses or physicians or RTs that come in that may not be as familiar with the unit owns the accountability and owns the process of what it looks like, which builds that resiliency to that team. Align policies to practice so that there's something to refer to and everybody can learn together and know what's expected of them in a very clear way. Visual aids are awesome, particularly with more complicated tasks. I cannot stress the importance, and it's been around in the NICU forever. Some of the adult units in the place that I work now are really starting to wrap their heads around how important pictures of intact dressings are, because there's so many different ways of putting them together, and some of them actually compromise the integrity of the dressing. Using peer audits performed in real time. So one of the things that I've seen be incredibly effective, and we stole blatantly from another institution, was to do random safety audits, which was basically just a deck of cards with those priorities that we had in the unit at a given time around CLABSI. And dressing integrity would be, as an example, let's say it's dressing integrity. You walk through the unit with the charge nurse, and at the end of rounds, you just blast the text out to everybody on staff. This is what our percentage of intact dressings was, and post it up on the wall. Simple run chart, post it up on the wall, do the same thing the next day until you get to 100%. When you get 100%, take the card out of the deck. And just track at the same time what's happening to your infection rate. So it doesn't have to be threatening, it can be fun. What I would say is that 20-item audit is never going to be successful. So start simple and try to hardwire things that way, and get people engaged in understanding it's not about them, it's about how we're doing as a team. And if we can't get to something, then we just need to make sure that somebody else can help us out or can't get there. And back to kind of finishing where I started: survey frontline staff to identify barriers that often reduce compliance. People will tell you where they're struggling, especially if you build that foundation of safety and believe what people are telling you in terms of what the solution may be, or where the challenges may be. We had a string of time where we had been at zero for almost 2 years, and we fell off the wagon and came up with a really elaborate plan. And talking to staff, they said, that's not going to work. This is what's going to work. And we did what staff told us, and we started it back, and we got back to zero. So I would stress listening to staff. They'll tell you the way. Next slide. So some tools for you from multiple different sources, all of which are available. The CPQCC QI Fundamentals is available to people who are CPQCC members. The others can be accessed by anybody. All you have to do is register. Next slide. So some outcome and process measures: monitoring serious safety event rates if you're of the HPI methodology, monitoring HAI events in published days since last infection. I think this is incredibly important, but at the same time, an ability to take action where using something as simple as a run chart with a process measure can be very helpful. And looking at error reporting as a proxy measure for speaking up. If everybody says everything's fine, odds are everything's probably not fine, but people don't want to talk about it. So really try to get staff to report whenever anything goes awry, because we want to catch those near misses before they lead to something happening like a CLABSI. And I think that's what I have.
Great, super, thanks, Nick. Back to Robin.
Okay, my section was sort of a potpourri of items, but really looking at widening our thought about hospital-acquired infection. And although CLABSI is important, you need to look at those processes, but are there other potentially synergistic practices that could bring down overall hospital-acquired bacteremia? First slide. So my methodology was really to not avoid duplicating these incredibly comprehensive national guidelines, and my next slide shows you where to go for those. But encourage a shift of thinking within your unit, and maybe a larger focus on a quality indicator that would be non-CLABSI bacteremia as well. That shift in thinking might really begin to create even more practices that we all can learn from that will push down that HAI rate, which especially with more and more 22-weekers being part of our practice and the challenges with not only their skin, but the environment. I think that this is a really great time to consider what are these potentially new approaches. Next slide. So as you do look, one of the first steps in my section is to review the recently published 2022, including from the CDC, and compare how your practice lines up with what their recommendations are. And that's usually your first step. I want to reiterate what Nick said before. Standardization of your care practices is key. And different bundles can contain different items, and you may add a new piece to your bundle based on your current challenges. But be sure, again, that everyone knows what those practices are and they're actually using those practices. So standardization is key, regardless of what part of your bundles you are using. So these are the updated ones that are all referenced in my section, both the CDC, the Shea White Paper, as well as there were new infusion therapy standards of practice. There's updated SPS prevention bundles, as well as the NAN guidelines for PICC lines that are all available to you that you should review and go ahead and identify which ones make the most sense for your unit. Next slide. So in my section, details matter, and I think that's really a big message for today. Whether your hand hygiene practices our compliance numbers are high, really need to dig into the details. The same would be here in my section, that each NICU is working with varying supplies, varying equipment, and have your own challenges that impact all your practices of HAI prevention. I'd like to broaden and encourage units to consider the GI tract of a source of HI and what can we do to help that GI tract be healthier. Of course, an all human milk diet is associated with a reduction overall in HAI, but are there other items or other things we can do to improve the infant's gut health? Using families as partners in HAI prevention. So there's not much in the NICU literature specifically about how to go about doing this, but certainly in oncology literature, in some PICU literature, there definitely have QI publications kind of using families to assist them with hand hygiene reminders or even audits. And I think this is a really important time for us in the NICU to consider how to go about doing this, how to do this in the safest way where all families and staff feel comfortable using and leveraging the families as working with us to reduce HAI. The NICU environment is potential impact on HAI. The overall bioburden within the isolate, we in the NICU classically have orphan equipment that nobody owns except us in the NICU. So who is taking care of that equipment? Who's cleaning that equipment? How is that cleaning happening? And that might be a method for us to reduce the burden of HAI. And then, of course, as Rochelle already mentioned, our high-touch cleaning opportunities are huge in the NICU. As Sue mentioned, we're working in a bunker. How do we work within that bunker? And how much hand wiping down can we do in the NICU? And then finally, in the NICU, specifically on HAI reduction, identify maybe the highest risk patients that are most likely to experience bacteremia. What are those patients? Who are those patients in your unit? And every positive blood culture is an opportunity to drill down and understand what might have happened. So there's forms that we've included in our toolkit that can help you use to look at every positive blood culture. What could that be? And then finally, I did look at the literature for adequacy of RN staffing, unit organization, and presence of support personnel, which kind of leads to the quality of the NICU environment. Another emerging area with not much information yet, but definitely does impact some of our breastfeeding rates and our successes in other areas. So I think this is another area that units can consider exploring and seeing what kind of effect we can have on HAI reduction. Next slide. So I did want to highlight partnering with families in HAI prevention, and this is from UCSF and Benham Children's Hospital. They have examples of really great tools about how to talk to families about maintaining the clean environment. What I loved about this tool is how can families help us maintain the environment around the baby to be clean? Things like take some of their own personal things home so we can actually clean. You know, these are simple things, but I think they can have a great impact. Do families know what HAI is? Do they know what eclampsia is? I think these are really great examples that you can take to your unit and start working with your family or parent advisory councils if you have them, and really work with staff about how to navigate the pros and cons of how to work with families. We definitely need more work in this area to publish. From all of you on the call, there's much we can learn from each other about including families in this work. Next slide. So my outcome and balancing measures are really looking at all hospital-acquired bacteremia, even, you know, the UTI infant who experienced a bacteremia. You know, we don't think of that as preventative, and we don't have that data or evidence, but could that be a section that we could explore more? Track your rates of human milk at discharge. You know, the more human milk we use and do at discharge, the less HAI we're going to have. Overall, look at your NEC rates related to your human milk at discharge. And then I can't say enough about auditing. I think auditing is helpful, but it has to be the right audit. You can't audit yourself to death. So you do have to pick and choose. Nick had a great methodology for doing that, but choose the area that is probably most problem prone for you, and then audit that, improve, and move on to the next. So audits are an evidence-based practice to maintain and sustain what success you might be having at eclampsia reduction and HAI reduction. Okay, that's it for me, I think.
Thanks, Robin.
All right.
Over to Carolyn, and we are running a little bit behind schedule, just so you keep that in mind.
Okay, well, thanks again for inviting me and for asking for my input on this particular segment of the toolkit, skin considerations. As many of you know, I've been a clinical nurse specialist for many, many decades here at UCSF Benioff Children's Hospital, the Oakland campus, and I've been interested in skin for a very long time. Next slide, please. So just by way of introduction, the skin is an important barrier, both to toxins that can be applied to the skin, but also to microorganisms. And I've found it interesting that the skin of premature and even full-term neonates has very unique anatomic and functional differences that can put them at risk. And the two areas that I selected for this section is that they can have problems with skin disinfectants that are used to decontaminate skin, and they can also have problems from medical adhesives. I want to point out that premature infants are particularly at risk for skin injuries from these products because they lack the significant barrier function because they have far fewer layers of stratum corneum, which of course is the uppermost layer of the epidermis. Next slide. So the potentially better practice that I selected for the first one is the recommendation, as we all know, to disinfect skin surfaces prior to insertion of central venous catheters. However, I do want to make the distinction in terms of the source of infections. Infections that arise from both insertion and dressing changes are considered an extraluminal source and can be prevented by skin preparation with disinfectants, among other things. But infections from an intraluminal source can also be prevented by adherence to aseptic techniques for catheter hubs, caps, connectors, and even how we string our IV tubing. In fact, Mermel and his colleagues have identified intraluminal as probably the more common cause for eclampsias in the NICU. And so he published that he could attribute intraluminal sources for as much as 60 to 70% of CLABSIs. And I have to say, in our NICU, putting our efforts into prevention through the intraluminal source by standardizing and really observing every single staff member in terms of how they string their IVs, how they access their catheters, so that we're really observing and making sure adherence is there. And we've now been at zero for a number of years. And I have to say that through the pandemic, with all the retirements and the traveling nurses, it's been a real challenge to get everybody rowing in the same direction. But I feel very proud and confident that we will be able to maintain our zero status. Next slide, please. So it has to do with selection of a disinfectant. And when we look at disinfectant literature, there's risks and benefits that have been attributed to all of the products. The products that I've listed here include chlorhexidine gluconate. The most common chlorhexidine gluconate product is chlorhexidine gluconate that's made together with 70% isopropyl alcohol. That's the ChloraPrep product. But there's also an aqueous CHG in the United States. It comes in a bottle, 4-ounce bottle. It's not very user-friendly. It doesn't have single-use packaging. I'm hoping that this will change in the future because in Canada and in many European countries and in Australia, they do have aqueous CHG in single-use products, but we don't have that in the United States yet. There's also 10% povidone iodine, betadine, and 70% isopropyl alcohol, which has been shown to be the least effective skin disinfectant. Now, what do we know about CHG? We know that it has been shown to reduce contaminated blood cultures in pediatric patients. We know that it has not been shown to reduce CLABSI in NICU patients compared to povidone iodine. We know that both CHG and povidone iodine can be absorbed into the bloodstream. And there's one paper, a fairly recent paper from Ireland, that says we're really worried about thyroid toxicity. In our population that we've used povidone iodine, they randomized to either CHG or povidone iodine. They saw a number of patients that needed thyroid replacement. Thyroid effects are thought to be transient, and yet they're concerned and they would vote for CHG. We have also seen some studies where they were able to measure CHG in serum of babies who had their skin prepped for PICC lines and central lines. And although we've not seen reports of systemic toxicity, we also don't know if CHG crosses the blood-brain barrier. The one thing we do know about CHG is that it can cause skin irritation and chemical burns, especially for low birth weight infants in the first week of life. Next slide, I have some examples of that. And you can see the two pictures on the top. The babies clearly had skin prep before umbilical catheterization. The classic situation is the 26-weeker who's on a radiant warmer for the insertion of lines. But I also want to show this poor little one on the bottom. That was a recent case that came to our NICU with a terrible blistering chemical burn on her back. And this was because she had had her skin prepped for her umbilical catheterization and was laying in a diaper soaked with CHG isopropyl alcohol solution. So you can see just how considerable damage can occur from CHG. Right now, the FDA says that you can use the ChloraPrep product in premature infants with caution, noting that it can cause chemical burns. Next slide, please. So the third PBP that I identified were to standardize dressings that minimize catheter migration and extraluminal introduction of microorganisms. So we've talked a little bit about PICC dressings, and I think the toolkit does contain some really nice examples. We do recommend that they're changed when the dressing integrity is compromised in any way. There should be a standardized technique. And in fact, we have a PICC dressing kit that really has helped standardize our practice. 2 persons using sterile technique is the recommendation. If bleeding is noted at the insertion site, you can use a sterile hemostatic agent to assist with adherence. And if bleeding obscures the insertion site, change the dressing after 24 hours. The little disc that I show you on this slide is such a hemostatic agent. It's called a stat seal. Now, there's also clear tissue adhesives that are made of the chemical cyanoacrylates. Some people call it glue. And this can be applied to the insertion site after initial placement and with dressing changes. You know, we used to use steri strips for this. We no longer do. We use this product called Secure Port IV. I think it's the only product right now that is FDA approved for this practice. And the benefits of using this product include prevention of catheter migration. It's also a barrier to infection, promotes hemostasis. And these are based on studies that were done in adults and pediatric patients. I've not seen published studies yet in the neonatal population. Next slide, please. This is the potentially better practice 4, and that's to use products and techniques that minimize the risk of medical adhesive-related skin injury. The acronym MARCI is somewhat new. There's a white paper that was published covering a number of patient populations talking about the problems of MARCI. And they described some of the types of MARCI that we see. Skin stripping in the premature infant, even the full-term baby, is the most common that we see in our NICU. But you can also see blistering, you can see skin tears, and you can also get a contact dermatitis reaction to some of the transparent dressings that we use. Now, to prevent stripping, you can use silicone-containing products, skin protectants, to create sort of a platform for your adhesive products. You can also use silicone-containing adhesive removers, and that's the one that I am really promoting a lot in our NICU to prevent the injuries and the stripping from adhesive removal. We've always advocated avoiding the use of tackifiers, and these are products such as tincture of benzoate and mastosol, because they create such an aggressive adhesive attachment to the uppermost layer of the skin that you can actually create more stripping because the epidermis is not as securely attached to the dermis, particularly in a premature baby. And if you do see contact dermatitis reactions, you can sometimes switch to a different brand or formulation of transparent dressings. Next slide, please. I wanted to show you what the contact dermatitis looks like. And, you know, classically, these are babies that are in the hospital for a really long time. We see contact dermatitis on the face as well as on the chest with a Broviac. But over time, the babies become sensitized. And I think it's because of the breaks in their skin. And then they develop these contact reactions. Now, this little baby on the upper left was reacting to regular Tegaderm. And our baby on the right was also pretty sensitized to regular Tegaderm. It turns out that Tegaderm 3M makes a Tegaderm HP that has a very different acrylate formulation. And these both babies were able to tolerate the HP product. But there's other transparent dressings that you might consider. Next slide. And this is my last potentially better practice. And this has to do with extremely low birth weight infants with central lines. You know, these babies, if they have a skin injury, really recommend finding out what their skin is colonized with. And this is because the skin injury can be a portal of entry for infection. So in other words, it might be caused by MARCI or a chemical burn. But what can happen is that if they're colonized with a pathogen, they might get quite ill with bacteremia. And it's good to know what they've got on their skin. So, you know, classically, we would consider invasive fungal dermatitis, but I've seen babies who we thought it might be a fungus and it wasn't. We've seen Pseudomonas, Serratia, E. coli, of course, MRSA. You can use topical antibacterial and antifungal agents if you know what you're dealing with. If it's MRSA, you might want to use mupirocin. If it's Candida, you might want to use Nystat. And then we do cover these, you know, ointments and such with a silicone dressing. There's a number of papers about using medical grade honey and silver containing dressings over skin breakdown in the premature infant. And those are in your reference list. And if skin is colonized with Candida albicans, there are a number of papers that recommend considering systemic treatment. just go right to fluconazole or an antifungal agent, because that frequently is the portal of entry with those organisms. And I think that's the end of this section.
Thank you so much, Carolyn. Over to Dr. Talal Sadek.
Hi, thank you. Thank you all for joining. And I'm Talal Sadek. I'm one of the pediatric infectious disease physicians at Stanford. But I also mainly work at the joint venture with Nick, with John Muir. And so I wrote the antimicrobial stewardship and the multi-drug resistant organisms section. And you might think like this, how is this section, how is antimicrobial stewardship helping with HAI prevention, and how does it tie in with multi-drug resistance? And that's what I'm going to go through. Next slide, please. So we know that from studies that prolonged antimicrobial use in the NICU is associated with higher rates of necrotizing enterocolitis, higher rates of multi-drug resistant infections, and is generally associated with neonatal mortality. So that's why it's important to have some sort of antimicrobial stewardship, and that's how it ties into HAI prevention in general. Next slide. How it ties into how do we prevent excessive antimicrobial use? You can start with a diagnosis, because if you think about it, accurate diagnosis will lead to, if you reduce inappropriate diagnoses, or for example, like UTIs or VAPs, we know that a lot of times we overdiagnose them. You will reduce antimicrobial use. So one of the things that we included in the toolkit that is somewhat of a, I wouldn't say new, but it's underutilized method of decreasing antimicrobial use is diagnostic stewardship. And also you want to prevent excessive antimicrobial use if the diagnosis is made, so that's where antimicrobial stewardship comes. If you think about it too, like we had at our institutions, for example, we had a lot of HAI, like a higher HAI rate. So we looked at what these HAIs are, and it turns out a lot of them are UTIs. So we went back and said, how are we diagnosing these UTIs? So if you think about it, your rate of HAI could be artificially high if you're not practicing good diagnostic stewardship. So those are some of the links between stewardship and HAI prevention. Next slide. And how does antimicrobial stewardship ties into MDRO, colonization and infection? And so we know that excessive antimicrobial use will increase the rate of MDRO infection and colonization. And also, if you think about it, if you have a lot of MDROs, you will use more antimicrobials. So it's kind of a vicious cycle, and we see this a lot with our intubated patients who are getting a lot of respiratory cultures. So that would be a good example for that. Next slide. All right, so in the antimicrobial stewardship, well, in the stewardship section, diagnostic and antimicrobial stewardship, the potentially best practice guidelines kind of guide you through steps on how to establish an antimicrobial stewardship effort or program in your NICU or generally in the hospital. And the first step is to find key stakeholders in multiple disciplines. So that includes nursing, APPs, physicians, pharmacists, and so forth. And so you'll identify champions who will help you throughout the way. And then you would want to have some measure of how much there are antimicrobials used in your unit. And we'll go through what measures there are that are available. And then you develop antimicrobial and diagnostic stewardship interventions, and then follow these measures longitudinally or compare them to other institutions. And then the last PVP that we included is to develop clinical pathways and guidelines for common neonatal infections. And the reason why we specifically targeted this out of all the other interventions that you could use, because I think it's very, very important in the NICU because NICU practices are different and the evidence is mixed on how to diagnose and treat some of the most common infections in the NICU. So having everybody on the same page a lot of times reduces variability and improves outcomes in general, and will help you look at those outcomes and what people are doing. Next slide. And so the approach to MDROs, I would summarize it in one word, is detection. And so you do want to know how much, if somebody, I would say, and more importantly, if somebody is infected with an MDRO, and I think we focus on MRSA and gram-negative rods because these are the broader, the two broader categories that we encounter in the NICU. So you would want to have measures to detect infections and plus minus colonization, depending on your NICU practices. Next slide. To measure outcomes, which is what we alluded to at the beginning about stewardship in general. As you all know or should know, CPQCC has its own figures and all the NICUs who report to CPQCC will report these figures, and those are the first two, AUR and NAE. AUR is basically the antimicrobial use ratio rate, which the definition is here. And then the NICU, the neonatal antimicrobial exposure rate is how many of your newborns have gotten antibiotics throughout their hospitalization. One more measure that we included is the days of therapy per 1,000 patient days, and we included this, I think, because a lot of it's not NICU specific, and you might see it from your ASP program that they're following this. And they basically look at how much there is antimicrobial use per the census, and they put it into 1,000, the denominator into 1,000. So this would be an example of, over time, meropenem use per 1,000 patient days and how it dropped after a intervention. So that's how it could be helpful. Next slide, please. For the outcomes of MDROs, you have a lot of measures that are proposed, and again, it's going to be very, very variable between NICUs. You could look at rates of MRSA colonization. You need to have an MDRO policy or know your MDRO policy specifically for gram-negative rods, because it is variable, like what the definition of an MDRO is from center to center, and whether you should isolate those patients or not. So we do encounter sometimes that people didn't know that this patient needs to be on isolation, or they're isolating a patient who doesn't need to be isolated. So it's important to know that there is an MDRO policy and what it is specifically. And to make sure that there is a system in the hospital, which talking to your infection prevention folks will help know how they figure that you have an infection with an MDRO, especially gram-negative rods. This is an example of one tool that we included in the toolkit, which is the antimicrobial timeout or antibiotic timeout, which is kind of a step back at an interval, let's say 2 days after starting an antibiotic, and taking a step back and time out and say, hey, do we still need it? Are we on the correct antibiotic? Can we peel one of the antibiotics? Do we need to increase the antibiotic because the patient's not doing well? All of that. And so, next slide. This would be an example of how it would be filled. So it'll force you to think, what am I using this antimicrobial for? How long am I going to use it? And what interventions I can. And that's my presentation. Thank you.
Thank you, Talal.
Okay, we're almost short on time. Just quick summary. Those are our sections of the toolkit. And next slide, Janine. It just highlights everything we kind of said over the last 45 minutes or so. And I think take-home points for me is HAI continues to burden our NICU patients. So I think wherever you sit on your own activity on HAI, I know we can all do better, and we should consider some of these potentially better practices to move that arrow down, as Henry showed us on one of his last slides. So really think more broadly, not just CLABSI, but look at all your practices in the NICU and see where you might be able to impact your HAI incidents. Janine?
Great. So let's go ahead and start with the Q&A panel discussion. We have Mindy Morris and Linda Lafrac moderating this section.
Great, thanks a lot, Janine. We have been taking a look at the questions coming in through the chat, and so we're organizing them. So we'll ask a few questions. I just want to stress, though, that if we don't get to all of the questions, we'll make sure that we get the questions posted to the authors and the answers and get that sent back to the attendees after the webinar. And I just want to thank all of the authors for not only their time today on the webinar, but the months and, well, I guess I should say years that they've been working on the toolkit. So thanks so much. We'll start with a question to Rochelle. A question wanting you to comment on the use of using hand hygiene gels versus soap and water.
So the guidelines haven't really changed very much in that arena. So soap and water is definitely recommended if you have visibly soiled hands. The benefit of hand gels is that they can be easily accessible. So you have them generally at the patient's bed space or entering and exiting patient rooms. And so it's a little bit more accessible. But I do know with supply chain shortages during COVID, as we all experienced, I know we got a product at one point that was a higher alcohol content, and then we did see more breakdown on staff's hands. So I think how we address this in the toolkit is just trying to select products that are easy to use by your staff and that don't produce a lot of contact skin dermatitis or skin breakdown for your staff.
Okay, the second question, and I'm going to direct this to Robin, is, can you hear me?
Yes.
Yes.
Yeah, so the second question, which had a little bit of back and forth discussion in the chat, had to do with the use of cell phones by staff or families in the bays or the rooms of the patients. Could you address that, Robin?
Yeah, there is some literature regarding cell phone cleaning and how to go about that. I might have briefly mentioned it in my section, I'm not sure, but there wasn't a lot of information. And I think all of us on the call know how challenging cell phone use is with our parents, including ourselves. And so there was a comment in the chat about a UV light, and I find that really curious. We have one also, and I do wonder what the benefits that might be, but I don't think there's enough data to say one thing or another. But I do know it's almost incredibly difficult to have families not access their phones. And so plastic bags have been used, and some units continue to do that. I just don't have enough evidence to suggest what that practice would be at this time.
Thank you, Robin.
Carolyn, just a couple of questions coming in about use of products. I'm going to combine a couple questions. There was a question about, is your 10% iodine sterile for the site cleansing? And then their previous question about use of CHG in the preterm infants. So I think you spoke very eloquently about some of the evidence we have for both of those, but just maybe what the recommendation of product use for the preterm, especially extremely preterm infant, and then thinking about how these babies are now 22, 23 weeks.
So the unfortunate news, Mindy and everybody, is that there is no universally agreed upon safe product to use for neonates and particularly for extremely low birth weight infants. And there's a number of papers that say that straight out. That's what the skincare guideline says. And so I don't really feel that we can, fault a unit for using 10% povidone. And there are many units that choose to still use that on these extremely low birth weight infants when they're placing umbilical catheters. And I cannot fault that at all. I mean, I do think removing it carefully and completely is really helpful. With CHG, I think we thought for a while that it was CHG with isopropyl alcohol that caused those burns, but it turns out that there's reported cases with aqueous CHG products as well. I mean, the way skin disinfectants work is they kill tissue, and that's what it's doing to the skin cells. So it's really a dilemma. I don't think we've got a good product. I was reading something the other day. There's a whole different category of skin disinfectants that is in one European country. I can't remember which one right now. That I think this is an area that really needs to be worked on. In terms of the preterm infant, I guess the one practice that I'm most hesitant to either do or recommend is the whole body wiping, because in the past there were some terrible outcomes when we were bathing babies with hexachlorophene, with Visahex. And it's not the same as chlorhexidine gluconate, but it's in the same category. And the real question is, it's a huge exposure, their whole body, their surface area compared to their body weight ratio, and so on. And the question arises, does it cross the blood-brain barrier? Could it cause a neurotoxicity?
Ms. Carol.
Okay, the next question I'm going to send back to the hand hygiene author, Rochelle. And one of them had to do with, and I know Sue presented this part, but she's gone. Can you talk about the recommended leadership round audits that you have used for hand hygiene compliance?
I don't know that there's a set recommended interval for that leadership rounding. I think each unit's going to have to define that specifically for whatever their unique situation or challenges are. I know Nick during his section mentioned some leadership rounding as well, and maybe you round daily until you reach 100% compliance, and then you move on to something else to round on. I know in our unit, we try to do either twice a week intentional rounding or weekly rounding by leaders with staff and also with our families. But I think each unit is going to just need to establish what that looks like for their own unit.
Thank you, Rochelle.
And Talal, there was a question that came in from one of the participants when they registered asking what the recommendations are for decolonization of an infant with MRSA.
Yeah, so that's a very good question, and not one answer. And usually you're working with hopefully you're working with the public health department if you have an outbreak. In general, I would say the main tools that we use, and the first one is mifepristone twice a day for 5 to 7 days, and that's in the SHEA and CDC guidelines. So to me, that's less controversial. The other aspect of this, as Carolyn has talked about extensively, is CHG baths, and I think you would have to weigh the risks and benefits of that and make your own decision on whether you're going to use that or not. That did show that it will decrease the bacterial burden on the skin, but I would say if you're going to use it, you're going to use it somewhat. You don't have to use it every day, but you do have to use it in a continuous manner 3 times a week, whatever it is, until your outbreak is gone. If there's no outbreak situation, I wouldn't use CHG bath just routinely.
Thank you, Talal.
Can I add quickly that the CDC came out for recommendations for control of infections related to MRSA in 2020. So refer to those guidelines too. They do discuss the risk benefit of CHG bathing as well.
Thank you, Robin. And while you're on on the screen, I wanted to ask you if you could comment on a question we received before the webinar on how probiotics play into the HAI prevention bundle.
Yeah, that was in my section, and we left it as it's currently not recommended as a method to prevent HAI currently. There's not enough data. So that's where we sat with that as well. And we left it at that. I think those are something that might be coming in the future, but currently for HAI prevention, it's not recommended.
Thank you.
All right, I'm going to ask a question to Nick, and I really appreciated what you shared, as far as HRO and kind of that shared mental model. You mentioned something about, when you get started, maybe choosing one intervention and, really focusing on it, holding everybody accountable. But I was going to ask you more like, what do you think is the most significant step to support QI via HRO models?
I don't know that I can answer that. I think what I was suggesting by talking about having one item is if you can rally folks around something so I think hand hygiene is a perfect example. There's no argument, right? The moral high ground is there for you. So if you started with something like hand hygiene and really empower staff to talk about what it looks like to remind somebody to wash their hands. I mean, in the unit I work in primarily now, it would not be unexpected at all for an EVS worker to gently remind somebody to wash their hands. That's an expectation. That's how we all work together. And I think if you can set that expectation, to address one of the other questions in the chat, then the unit owns the culture. And so when people come in, the expectation is that that's how you'll behave because that's the way we work together. So whether it's a surgeon in a unit that has people buzzing in and out, whoever it is, it doesn't really matter. If it's an administrator, it's irrelevant. This is what we expect of you, and whoever you are, we all are going to support each other in doing that thing that's going to keep us safe. And it's one of the reasons I think hand hygiene, again, starting with it, it's kind of a gateway drug to all of the other reminders that you could offer to people, because there is no argument that if you didn't wash your hands, you're putting the patient at risk, and there really is there's no pushback on that topic. So I think starting with hand hygiene is an easy one, or an easier one, but getting people talking with one another and making it okay to have those conversations. Because honestly, most of the time, people are not trying to do something, they're trying to do the right thing, but in all of the various things, whether your phone's ringing or somebody's asking you a question or you're trying to put something in Epic and the next thing you know, you haven't washed your hands, it's just gonna happen. And we can't be as safe as we can be unless people help us.
Perfect, thank you.
Okay, so for our last question, this is a rough one. So for those that didn't get answered, as you know, we're going to send out those with the evaluation. And also just to mention that the toolkit went live today on the CPQCC website. So all of these links and references are available to you that have been referred to today. I'm gonna end, I guess, with the, I guess I'll go back to the hand hygiene question. And that is, this is a question that came in early. What are the specific recommendations for sterile line changes? That sounds more like a Robin question. Is it necessary in the NICU? I'll let you, either you, Rochelle, or Robin take that question.
Go for it, Robin.
For all the nurses, we love the details, of course, but there was a QI report that included that as part of their bundle, and they did have a reduction in their eclampsia as a result. Now, that's not in any of the other national public guidelines. It's not necessarily recommended, but I think whenever you're looking at interventions to reduce HAI, you do have to take it in context of your unit. And if you are struggling, you should consider additional interventions, and what those are, you'll need to evaluate in terms of your ability to do that intervention. And please don't do an intervention without monitoring moving forward to see how effective that intervention is. So again, I think that it's not in the national guidelines to perform sterile central line tubing change. But again, I have seen a QI report using that as one of their bundle components.
Great. Well, I think we are at time, so we'll go ahead and wrap up. So thanks everyone for joining, and a special thanks to all of the Toolkit authors and all of our QI infrastructure team in bringing this Toolkit release webinar together. Thanks so much.